Good morning. Hello, I'm Louise Glover and I am working at Shropshire Community Health Trust, and I am the lead for the MSK Alliance, which we've come to share an update with you and some information this morning. I'm representing the Director of Strategy, who is the chair of the Alliance Board, who unfortunately could not be with us this morning. However, I'm also a member of the Alliance Board and work very closely with Ros Preen, the Director of Strategy. With me, I have Richard Fallows, who is our clinical lead for the Alliance. And hopefully we will have one of our colleagues from Rheumatology Service joining us later for the questions session. So the purpose of today really is to share an update on the musculoskeletal service for Shropshire, Telford and Wrekin, and to give you an opportunity after you've seen our slides and we've given you the overview to answer any questions you may have. So if you would like to ask a question, you use the question and answer panel on the right of your screen, and the questions will be put to the panel, which will be Richard and hopefully Karen, who's just joined us from Rheumatology Service. And we will answer those questions after the presentation. Chris Hudson, who is our head of communications, will be comparing the questions. So when you hear a different voice to mine or Richard's, that will be Chris. And we've got roughly an hour in total. So the last sort of 30 minutes or so will be given over to questions. So I'm going to start off the presentation. So the MSK Alliance, or the Musculoskeletal Service, is made up of services provided by Robert Jones and Agnes Hunt Orthopaedic Hospital, Shrewsbury and Telford Hospital, Shropshire Community Health Hospital, and we're working in conjunction and partnership with Shropshire and Telford and Wrekin clinical commissioning groups. The next slide, please. So how did we get here? Why do we have an alliance? Well, our county, Shropshire, including Telford and Wrekin, has a number of health-related significant pressures and performance issues, and these have been identified by Right Care, among others, and one of those services is orthopaedics. So, looking to the future of NHS-related healthcare, we know we are facing reduced budgets coupled with an increasing population, and this has an impact already on our musculoskeletal services, including some aspects of rheumatology. And additionally, people are generally living longer, therefore placing more demand on our MSK services in particular. At the moment, we have two services within Shropshire and Telford and Wrekin, and I'm sure many of you are aware of these services. We have Thames and Seuss, and they have different levels of maturity and different approaches from which we've learnt a lot. What we want to deliver is an equitable service for all of our patients across Shropshire and Telford and Wrekin. So we are a bit of a trailblazer, part of the integrated care systems that the NHS are beginning to roll out across the whole of the country. Next slide, please, Chris. Slide.
Hi, I'm Richard Fallows, clinical lead. Some of you as patients might know me as a clinician you've seen. What does the new system look like? Well, you can see on the slide there that we've got various layers, and we have a centre that's bright orange, and we've encompassed quite a large amount of services. So we have therapies, we have the interface teams that some people know of as Thames and Seuss, we have rheumatology, we have MSK pain, and we have orthopaedics, including orthopaedic elective surgery, and of course the rehabilitation afterwards. You can see that it starts with a single referral centre for the whole of Shropshire and Telford and Wrekin, and that this leads to some triage on the electronic integrated system, and then from there patients will be sent to the right place, the right clinician at the right time. Can I have the next slide, please? So who's sending the referrals? Well, this day and age, it's not just the GP, it's also the advanced nurse practitioners, and also this new group of professionals called the first contact practitioners in primary care, and they will have access and send in the referral to do with all those conditions we've talked about in MSK into the referral centre. They'll be electronically and clinically triaged by a multidisciplinary team and allocated out to whichever layer or level is appropriate to make a start at. This will be based on best practice, has been carefully worked out by the clinical teams, the multidisciplinary clinical teams across all of the organisations and professions. Being put into one level doesn't lock you to that level, and there's a very quick method of escalating people to wherever the next right step is, should the condition change or if more than one input is required. If we go to the next slide, please. So we've got a short clip, a short video to look at the old system and the old pathways and compare them with the new pathways. My apologies to everyone. As you know, we're in the middle of a pandemic, and the support teams made a very beautiful animation for us, and the overdubbing didn't quite work, and we haven't got the resources, so I've ended up doing it, and if it's not quite up to a professional standard, I do apologise. Right, let's start that animation. Oh, we've lost Chris, we've lost sound. We don't have any sound. Hi everyone, sorry about the technical issues. We haven't got any sound on that version, and let's...
Richard, I can resolve that. Apologies, we can try that again and we'll get the sound back now.
Okay, we'll try again. Sorry folk, here we go. We will now look at the two pathways, past and future. Beryl is 61 years old. Over the past 6 months, she has developed a pain in her foot. In the old way, the Beryl goes to the GP, who books her appointments to see a physiotherapist and a podiatrist. In the new way, Beryl contacts her GP practice and speaks to the first contact practitioner, who gives her immediate advice over the phone and arranges a face-to-face visit a couple of days later. Beryl sees the physiotherapist first and is given some exercises on the old pathway. In the new pathway, the FCP, that's the first contact practitioner, recognises that Beryl has a problem that may not be resolved by simple advice, and therefore she refers her to MSST, must. Unfortunately, the pain does not improve, and Beryl calls the GP again. The GP tells her to wait for the podiatrist appointment, as typical of the old way. In the new way, her referral is triaged within 48 hours and an appointment arranged with both the must physiotherapist and the must podiatrist at a location closer to Beryl. In the old way, Beryl goes to her podiatrist appointment, who gives her more exercises and advice and prescribes an orthotic for her shoe. In the new way, because of the prompt attention, Beryl copes with her symptoms well and is able to continue living her life. In the old system, the pain in her foot improved slightly. However, 6 months later, her symptoms change and evolve further up the leg. In the new system, she's contacted by the MUST clinical team via video link. Beryl and the team decide she needs a face-to-face appointment, which is arranged with the MUST lower limb advanced podiatrist and advanced physiotherapist. In the old way, after more visits to different health professionals and calls to her GP, she goes to visit her doctor again. The GP refers Beryl for further diagnosis in SUS orthopedic interface team. In the new pathways, Beryl goes to the appointment at the advanced practitioners and has an X-ray on the same day. A few weeks later, she travels to the local hospital for her MRI scan. The team contact Beryl via video consultation once there are results. On the old path, Beryl visits the SUS orthopedic interface team and is referred to an advanced podiatry clinician. On the new pathway, an agreement is made to see the orthotist and the foot and ankle surgeon at the local hospital. The surgeon will perform an operation at the specialist hospital. The new approach has meant that Beryl sees far less practitioners on her road to recovery. It also has taken her less than half the time to recover, and she hasn't needed to make as many journeys. Returning to the old way, Beryl goes to have an X-ray and an MRI scan. The X-rays are done 3 weeks later at a hospital, though she must wait 2 to 3 months for her MRI scan. In the meantime, Beryl visits the advanced podiatrist a couple of times and refers Beryl to the orthotics department. Beryl visits the orthotics department and discusses her MRI result with her advanced podiatrist, who can see a potential surgical target. The podiatrist refers her to the foot and ankle surgeon. After further travelling for several more visits, Beryl is seen her surgeon and podiatrist and has been listed for some surgery. Though Beryl's foot is much better, Beryl has spent over a year travelling to numerous appointments around the county. While Beryl received great care, this has been a long and frustrating road of recovery for her. However, let's turn back time and look at the new way. On the new pathway, Beryl has only 8 steps and took only 8 months for her treatment. Well, so there it is. My apologies for the technicals at the start. I'm going to pass you back now to Louise, who will carry on talking about the Alliance.
Just bear with me 1 sec while I set that up, Richard.
Okay. We're just swapping over from the video to the slides again. Oh, here we go. We're back into the slides, and we'll go to the next slide and Louise will continue.
Thank you, Richard. So you can see from the video that Beryl has a much smoother, shorter journey than in the new way than she would have done in the old service, and that's what we're hoping that we're going to deliver for you. So what will this service deliver? The MUST service: better access and quality of care, one single model across Shropshire and Telford, which means that wherever you live in Shropshire and Telford, you will have access to the same kind of treatment. One point of entry for all referrals. So your GP will have, or first contact practitioner will have, just one way of referring into our MSK service, not 2 ways as he or she may have now. Multidisciplinary e-triage, so your referral will come in and it will be seen by one of our clinicians, who will then decide which is the best way for your care to be offered. There'll be therapy first, aligned to best practice and seamless pathways. Rheumatology is included within the model, and there'll be access to pain services at all levels of care needed. Next slide, please. So what else will it deliver? A shared patient record, so that you won't have to repeat your history every time you see a different member of the team, if that's what your care determines. They will be able to read your record. It will be one record that all healthcare professionals will have access to. Be digital apps and access to diagnostics, and therapy-led post-op and rehabilitation care if you require surgery, and close working with mental health services. In that we mean that there can be quite a lot of benefit from psychological care, particularly with chronic conditions or such as pain, long-term pain conditions. Next slide, please. So what will be different? All staff will be working as one team, whatever their organisation. If you remember, I said that we have 3 partners within this alliance: Robert Jones and Agnes Hunt Hospital, Shrewsbury and Telford Hospital, and Shropshire Community Health Trust. And it doesn't matter where your therapist works, whether they're based in one of those 3 hospitals, they're all working as one of team, as a member of the MSK Alliance. They'll all be using the same best practice pathways that have been developed by the clinicians across the county, and they're standardised so that you're offered the same care, as I said, wherever you see somebody and whichever part of Shropshire and Telford and Wrekin you live in. Increased multidisciplinary triage, integrated rheumatology services, and we'll be bringing together teams with enhanced skills. Increased use of technology and clinical locations around Shropshire, Telford and Wrekin, with multidisciplinary teams in those locations. Virtual multidisciplinary team, advice and mentorship for all of Shropshire, Telford and Wrekin colleagues, probably the best word to use there. Okay, next slide please, and I think I'm handing back to Richard now.
So we've been talking to our staff and talking to our patients, and there were a number of comments on our referrers as well, and a number of comments we've heard, and you can see them on the screen, and things like that. Well, this is all about saving money. Well, you know, this is not the primary concern. It is about equity of care and quality. And it's about seeing the right patient at the right time, in the right place, with the right data, and offering best practice and equally across the county, both Shropshire and Telford Wrekin, whether you live in a rural area or you live in one of the conurbations. We're moving towards working together, and this is the primary driver. We wouldn't do it if it wasn't about quality of care and improvement. Is there saving money? Well, I hope so, because that means we can give better quality of care across the whole system in the long run. That obviously it's about keeping everything working well on all fronts. One of the other comments we hear is all services will be consolidated to Oswestry at the Robert Jones. No, we've worked really hard and about bringing the very best and subspeciality and being able to offer that out in locations around the county, and to balance and improve access across all the ways. Robert Jones, I know, I work there, is up in one corner of the county, and it can be quite difficult to get to. But what if we can bring some of that expertise out into the county? What if the different partners all have different strengths and weaknesses, and if we can bring all the strengths from each of the different partners together and then put them out in the community, then we feel that we've achieved some equity and quality for everybody. Staff will lose their jobs. There's not enough staff in the system as it has it. We're all highly pressed, and extremely so at the minute with this global pandemic going on. And no, we have no intention of making job losses. There is reconfiguration, of course, as we integrate things, but that is not our intention to cut down the workforce at all. Maybe redeploy and put in different places if it's required, but the vast majority is we don't have enough people, actually. Another thing that's come up is Telford residents are going to have a lesser service as the two services consolidated, and I've already gone through this in the points above, and that is not the case. GPs will be required to provide additional care as community services are reduced. And again, this is not our intention. We've looked to really become super effective within our own integrated system. And we hope that with the start of the FCPs, which are the first contact practitioners, who, although not part of our system, are highly integrated in with it, we actually will, in the long run, reduce any burdens as we get up to speed with the new system. So that really sort of gets us to the point. There's some questions that other people have put up. It's really, we need to hear your questions, and so we'll open the panel. You'll hear now Chris, who's got head of communications, is going to be our MC, and we've got on the panel here Louise, who you already met, who's the program head, and then we've also got Karen Daleman, and she's a senior manager and leader for rheumatology out of Robert Jones, and then of course myself. We are a little thin on the ground in the panel. We've done these previously. We've had a much bigger panel, but of course we're in the middle of a global pandemic, and a lot of the staff have been redeployed and rather busy. So if we can open the questions and answers.
Thank you, Richard. And already we've had a number of questions coming in. So we've got about 35 minutes, I think, still left. So over that time, I'm going to be putting those questions to you. And if you can delegate to members of the panel where appropriate. And I think we've already got questions that potentially will need all three of you to answer. So I'm going to start off with one of the more recent questions that came in, Richard. Has this pathway been signed off? And if so, when is the start date of the new design?
I think that's probably best answered by Louise.
I shall bring Louise right in now.
Thank you. Yes, the pathway or the general model of the service has been signed off by the Alliance board, and we have 7 or 8 specific models of care for specialities, and they're in the process of being signed off at the moment, and they've been worked up by our clinical colleagues, and using obviously best practices we've mentioned before. The service will start on the 1st of April, but it's going to start in a very phased way. As Richard's mentioned a couple of times, and we're all aware, we're in the middle of a pandemic, and a lot of our therapy colleagues have been redeployed from their normal posts to go and provide care for patients within the acute hospitals. So it's not the best time to start delivering a new way of working. So what will happen is from the 1st of April, GPs will start to use that single referral form that I mentioned earlier in the presentation. And that's the only change that is going to happen then. Those referrals will then go into the existing services that we have at the moment. But from the 1st of April, at a time when we can see that the pandemic impact is slowing down, we will start to introduce other phases of the service. And hopefully, and this is obviously a lot COVID dependent, I'm afraid, but hopefully we will have the full service up and running from about August onwards.
Thank you very much, Louise. While I've got you on camera, Louise, this might be one for you to start with, and you may want to bring in Richard, but we've had 2 or 3 questions about patient engagement, asking, have we spoken to patients in forming this new pathway? And if so, what have we done? And is there more to come in terms of patient engagement?
The answer simply is yes, we have over the past. I joined the programme in November, and I've been involved in one other conversation with patients, but I do know that there have been conversations before that, which Richard can tell you more about in a minute. But this is the first one of what we're doing at the moment, and we will be doing some more. So, Richard, do you want to answer that a little bit more?
Yep. Yes, in terms of patient and staff involvement, it started way back in 2019. And there was some engagement events back then, both from both sides, staff and patients. We've had, as we've moved through the development of some of the ideas, we've had patient rep. It's a critical and key meeting, the Nexus meeting, where all the different task and finish groups meet together. And this is today is part of that engagement. It has been a very difficult time. All the plans we had for doing things in ways that people are familiar with in January, of course, had to yield to the global pandemic and the stress upon the NHS. However, I know in rheumatology, we've had patient questionnaires go out, and I'll put that over to Karen to talk about that part of it as well.
Karen, you're live if you want to introduce yourself to the audience.
Oh, you're on mute.
Oh, Karen, yes, you have to unmute yourself, sorry.
Sorry, I'm talking to myself here. So I'm Karen Dallams, I'm the operational manager, well, on the head of specialist service for specialist service at Robert Jones. However, in this model here, I'm quite neutral because I led the service specification development for rheumatology. So what we did is really make sure that we looked at both what do we need to do around waiting lists, what standards of care do we want to introduce, and how do we make sure that we're providing the same service, across the whole of the county. And to that element, I think patient engagement really was quite key. So looking at where we got the patient engagement very specifically, some of it I think Richard and Louise alluded to, work that's been done as part of the Alliance. Some of it we also did as part of our BSR, which is the British Society of Rheumatology peer reviews that happened both at Thames and Robert Jones in 2019. So that was really quite rich for us to really gain what we did well and where we could improve, and came out with a lot of recommendations. So all of that, both the questionnaires and then also the BSR peer review recommendations, which included the patient element, have been used in developing the model. And we made sure that we assessed the whole rheumatology service specification against all of those recommendations and feedback.
Thank you very much, Karen. Thank you for that. And there'll be more for you in a while. Richard, I'm going to come back to you if that's okay. So we've talked a bit about patient engagement there. We've had a couple of more questions about that, but hopefully the answers that people will have just heard will have covered some of that off. Can I also pick up a question we've had saying, how long will it actually take from GP referral to being seen on this new pathway? So the person specifically is saying, when will a patient actually be seen?
We can't say when. We have very strong criteria how quickly we deal with a referral. So, for instance, a standard referral coming in electronically will be triaged within 48 hours. If it's urgent, it will be triaged in a much quicker time frame. it will then be designated to the right clinician. Now, if we've got this system right and we're working across the whole patch, we can now gather the whole resources of the whole Shropshire, Telford and Wrekin health system in MSK, which should mean that we have a lot more efficiency and offer appointments quickly and effectively. So whilst I can't say something will happen within, then we will obviously work within the RTT, and we've got high hopes for this to deliver great efficiencies in terms of how quickly patients get to the right person, the right time, and also in the right place, so you don't have to travel to the ends of the earth unless there's a real need.
That's lovely. Thank you very much, Rick. We've had some questions about specific parts of the service, Richard. So I'll put this to you, and you can tell me if other people are appropriate to answer this. Somebody says, will orthotics be included in the service? They're a bit concerned about medication for rheumatology sometimes. They say sometimes it's monitored by the consultant and the nurse, and when it's agreed to be working, that it's shared care between the GP and the allied health clinician with 6 months checkups. They say, how will this be in the new pathway?
I will answer the first thing about the orthotics. Yes, it is. The orthotics are definitely in part of this and very deeply integrated into it. So, and in fact, we're looking at ways of improving podiatry access into rheumatology. And so it's part of our integrated smoothness of an integration of movement for the patient. In terms of the shared care agreements, there is a monitoring system called Dawn out there, and it's not used equally across the county. So I'm going to pass you over to Karen. I'm sure she'll enlighten us further.
So yes, so the shared care agreements or the shared care model is currently in place across both county as part of the counties anyway. So Telford and Wrekin and Shropshire, and it's actually very, very similar. So we don't expect a big change to it. However, it's how we monitor it and how we really administer it that will hopefully become a lot slicker. As Richard alluded to, we use the Dawn system for monitoring in Shropshire and find that it really enhances how the system works, and particularly the timeliness in contacting our patients. So it reduces a lot of our risk. It takes the risk out of it. And as an integral part of like the new service specification, we want to roll out Dawn across Telford and Wrekin as well. I think the other big element in it is that because we're bringing both parts of the county together, we'll have a significantly bigger pool of staff to work across both sides. So it will make us a lot more flexible in supporting where the support is needed. So there should be, and that really is the aim of it, that there will be total equity of service delivery across the whole of the county. So if we're finding that waiting lists or different areas, if it varies, we can actually move our staff around significantly easier.
That's lovely. Thank you very much, Karen. Karen, while I've got you on screen, as our sort of resident rheumatology expert, if you like, can I put another question that we've had to you? Somebody says, where will a patient with rheumatology be seen, as they haven't heard of a blood test at the moment, and the video seems to be more MSK rather than rheumatology? And they also say there was no information in that video that we played on fibromyalgia. Sorry, yeah, did I say that right? You did say that right. So can you just maybe give us a bit of an overview of where rheumatology fits into this model?
So rheumatology is an integral part of the model. So the model really looks at the orthopedic patients, which is, you know, in all honesty, is the biggest chunk of it. However, rheumatology is a big part of this, and so is pain. So currently we're already seeing rheumatology patients across the whole of the county. We've got, I think going forward, don't want to call them up, but two main areas we'll be seeing patients, which will be in Telford, currently Euston House, but we are looking potentially at using PRH in this as well, and at Robert Jones. But we've got quite significant or smaller clinic sites as well. So we go out to Shrewsbury, we go out to Newtown, we go out to Whitchurch. So we've already got quite a few different areas within the county. So I think going forwards, bringing both of these sides of the county together, it will make it significantly better for our patients, because you will have a choice where you want to be seen or who you want to be seen by.
That's lovely. Thank you, Karen. Karen, Richard, sorry, I'm going to bring you back in now. I'm going to give one more specific question before we go to some more general service-wide questions we've had. But somebody's asked specifically about whether there'll be a rheumatoid arthritis helpline and will that be properly manned. I'm assuming there's an issue there that they're referring to.
Yeah, I'll answer the question regarding fibromyalgia, which it's not Karen's thing, but we're very involved in redoing and re-looking and reinventing the MSK pain service across Shropshire, Telford and Wrekin, and and supporting our chronic pain patients. So we've got very ambitious plans to change this and deeply integrate it in with all of the services, including rheumatology. And we're hoping to have some very specific ways of helping our fibromyalgic patients in there, along with our other patients. So we're again really aligning ourselves to best practice for dealing with chronic MSK types pain and symptoms. And so I'm very hopeful that that will offer some useful support for our fibromyalgic patients. What was the original question again? This is the question again. Sorry, Chris.
Thank you. Yes, Richard. This was a question about a rheumatoid arthritis helpline. Somebody has specifically asked, will there be a rheumatoid arthritis helpline that's properly manned? I'm not sure, but from the question, I'm assuming that there's been an issue there, and I'm hoping you might be aware of it.
Yes. So the services have been stressed, and I think that the stressed across, particularly in Telford, and I think that this has been looked into very deeply with the reviews that Karen's talked about, and we're very confident that we can offer a very holistic and stable service that's equal across the whole county and Shropshire, Telford and Wrekin. And of course, running a rheumatology service requires that helpline, and it needs to be managed, and of course that has been written into best practice.
That's lovely. Thank you, Richard. Okay, I'm going to take you on to some more general questions we've had again, having done a few specifics there. Julian asks, are GPs on board with this programme, and can they send patients straight to consultants as they can at present?
I think I'll answer that one. Is that our GPs on board? GPs were involved at the very start of this. We've had GP invites for GPs onto our various meetings. It's not been the best time for them to come along to transformational meetings. They've had their hands full very much with this pandemic. And we recently had some meetings with the GPs, and we've got further engagements coming forwards. Just tell me the question again. Sorry, Chris.
So we were being asked, are GPs on board with what we're proposing to do? And specifically, that Julian also asked, can patients be sent straight to consultants?
Oh yes, straight to consultants. Well, this is all based on best practice. So there is one place in to the system, and then it's triaged by its clinical need. So if the clinical need and if all the criteria are point towards a patient going direct to the surgeon, then that is indeed the case. That will happen very quickly. It won't be the faffing around. While if best practice indicates they might need some clinical workup, they might go to the interface layer to get that workup first to get a diagnosis. If it's the sort of input presentation that's doesn't require surgery, then it will probably go to and it's fairly straightforward. It will go for therapy if that's what's best indicated. If at any time there's a change, so if you start, let's say that there needs to be a diagnostic workup, and then at that level it's seen that surgery is the next step, then that will be arranged there. And because of the quick flow through that will arrive at the right surgeon in the right place with all the workup done.
That's great. Thank you, Richard. More specific, more general questions, sorry. We've had a question anonymously asked where somebody says that there's previously been talk of being 4 locations where this service will run from. Is that still the case? And if so, where are those 4 locations?
Louise, do you want to answer that one?
Yes.
Okay.
There has previously been talk of 4 locations. However, we are looking at what locations would be most suitable for what we're looking to deliver, and there may be many more than 4 across the county. For example, it could be in Ludlow, could be in Whitchurch, it could be at Euston House, it's already been mentioned in Telford, it could be at PRH, it could be at Royal Shrewsbury, it could be at Robert Jones. We're still looking at exactly where the best options would be. As we said, we're trying to provide service that makes access for our patients easier so that they don't have to travel from one side of the county right across to the other side unless that is absolutely necessary, because that's where the specialists are. But the whole aim is to bring the specialists and the therapists out to locations, many locations across the county.
That's great. Thank you very much, Louise. A follow on from that, a separate question we've had was said, will the hubs that we set up have X-ray or scan facilities, and also will they be able to do blood tests, or will people have to go to other destinations for those sorts of services? I can see a hand up from Richard if you want me to pass to Richard.
Yes, please. He's keen to answer that one.
It's not fair to ask Louise to answer that one. Yes. Now, obviously, we can't magic radiology units out of thin air. There is a little bit of an exception to that rule. However, we aim to put services that require heavy use of radiology and blood tests in the place where the patient is. While I can't promise one stop for everything, that is our golden, that's our goal. If we can get close to one stop as we can, so we can get a multidisciplinary team in a place, and that, so that may necessitate having some of our services, maybe something like rheumatology, where we're a heavy user of blood tests, a heavy user of investigation such as radiology. Then that it would make a lot of sense, provided we can arrange that, to have that in places where those services exist. We have actually underutilized community radiology units out in some of our community hospitals, and we're investigating how to use those with some of our orthopedic subspecialties as well. And certainly with the early inflammatory arthritis pathways, again, we're looking at the practical and realistic use of some of these services around the county.
Thank you, Richard. We've just had a question come in that's more of a comment, really, but given we've just been talking about locations, etc., I thought it was relevant at this point. So somebody says we should maybe canvass patients as to where they would like to be seen and how they currently access treatment. It's important to hear what patients would like to travel, where patients would like to travel to. Remember that not everyone has transport, and public transport is limited. And I think that's kind of what we were saying, wasn't it? That
Yes.
We're trying to deliver a service that makes it easier for people to be seen closer to home.
Absolutely. I can see Louise nodding her head, so perhaps you'd put her on.
Yeah, that's a very valid comment. Thank you. And we really are trying to provide service from the easiest of places for patients to get to. We can't provide a service in every single village or town across Shropshire and Telford. That just is not realistic. But the nearer to people's homes, the better we are trying to do.
Thank you, Louise. And off the bat, I don't know if it's the same person, but another comment came in just, which is very similar. They say when looking at locations, car parking needs to be considered as well. They say free car parking is not available at the bigger well, they say at hospitals, but certainly not at Shrewsbury and Telford and Oswestry, and that can be a concern for patients as well. And I'm sure that's factored into our thinking, isn't it? And again, I can see Richard putting his hand up. So Richard, would you like to respond to that?
Yes, it's a hard ask, isn't it? Where we to offer all of these golden things in all of the locations around the county. We find that the community positions locations don't charge for their car parking but they can sometimes have limited car parking. It is very much one of the things that we consider, and it's certainly on the list when we're assessing the venues. We will, I promise you, we'll try to do our best to find the best fit to achieve those aims. And I know it's particularly important for our rheumatology patients, with, you know, because they often have to attend quite regularly.
Thank you, Richard. I'm going to give you one more clinical question before I move on to a couple of other areas. Somebody's asked who does the triaging. I think that was Julian again. And I suppose going back to Beryl's story, we saw in the old model Beryl going to the GP, and in the new model she was being seen by or talking to the FCP. So could you maybe just explain that a bit more for people in terms of how a patient is triaged?
Yes, the patient is triaged. I think the whole system of medicine's changing, and it's not just from our front door at the referral centre. It's changing out in primary care as well, and so some of the initial diagnosis will potentially be made with the GP. It may be made with FCP, and I know some of our advanced nurse practitioners are involved in this with support from the GPs. So the diagnosis may start there, and some of the working up. I think some of the FCPs are being empowered to do some of the workup and investigation there. When they enter into the referral centre, there are teams of and layers of triages. So straightforward triage is done by pods of AHPs who will look at referrals which are suitable for their profession, and they will pick out those things that are suitable for therapy. Anything that is not very clear to them, or there's any doubt, will be passed on up to the next layer, which will involve specialist and advanced practitioners like myself, but also doctors with special interest. And then at the same time, rheumatology referrals will be fast-tracked through to the rheumatology electronic triage, which is done by the rheumatology team. So you can see that we've got a very quick fast-tracking system. Nobody can hold that referral for long. It has to move quickly through. If there's a doubt, it gets escalated. And then all along this, the subspecialities are supporting those teams through the new communication methods that we have these days.
Thank you, Richard. Just one more actually that's just come in clinically that I think hopefully you'll be able to give a very straightforward answer to. Sylvia asks, will there still be patient choice? So if I wish to travel to Oswestry for surgery, will it still be my right to do so?
Absolutely.
That's what I thought you'd say. So I think that's one we can categorically say that, yeah, if a patient is recommended for surgery, then they would have the right, wouldn't they, to choose exactly where they want to go.
Patient choice is fundamental to our NHS structure.
Lovely. Thank you very much. I'm going to take you on to a couple of non-clinical aspects. IT is clearly important to all of this, Richard, in terms of how our organisations speak to each other and share records. And somebody asks, is the IT in place to effectively share patient records?
It's a long way further forward than it was even 12 months ago. It's partially helped. I don't want to say it's a benefit, but it was something that's been accelerated by this pandemic. And there's a lot of interest across the country. We've had a lot of push to get all these parts. They've always been part of the plan, and we all, as clinicians, we all recognise that. And Karen was talking about bringing the systems together in rheumatology. We are very much working very hard at that. as you can imagine, our IT teams to get it absolutely right have been taken up organising a lot to do with the vaccination and COVID programs. So we're giving them a little bit more time to be absolutely sure we have the right things in place for this.
Thank you very much. Right, we're running low on time now, Richard, so I'm going to try and get through 2 or 3 more questions if we can. There's a couple here where, to be honest, I'm hoping you will understand the question, because with my non-clinical head, I don't. So I was
hoping for a question for Karen or Louise, but never mind.
I've got a couple that they may be straightforward, but if they're not, then I apologise. I'm being asked here, can you say what dawn is? Dawn, D-A-W-N, capital.
I'll pass that over to Karen. My wish has been granted.
Oh. You're on, Karen.
I wish I would have the answer. I don't actually, we always call it DAWN. I don't actually know what the acronym stands for, but it's basically a monitor system for any of our patients that go on to certain drugs, particularly like the drugs that can have more impact on patients, need to be really closely monitored. So it's just like a safety net database that our clinical staff can use to ensure that if you are put on certain drugs, that we can monitor your we can closely assess your monitoring intervals.
Thank you very much. That's helpful, Karen. Thank you. Richard, on similar lines, in terms of people asking specific questions, presumably on feeding back on things they've heard, I've been asked here, will MSK be part of the PIFU, the patient-initiated follow-up, and has that started already? Do you understand that question? Because I'm afraid
I do. Yes, very. I don't know whether Louise can answer that one, but is she ready to? No, I can't tell. Yes, she is. Yeah, we'll send that one to it.
Yeah. Yes, MSK is very much going to be part of PIFU, as we have to call the acronym, but patient-initiated follow-up. Basically, it means that, in essence, a patient is discharged from the care, but if they need to come back, they can initiate that follow-up, so they don't have to start the whole process again. But yes, MSK is going to be part of that. It's frequently talked about in all of our sessions.
That's lovely. Thank you very much. Karen, I'm just going to bring you back quickly for one more rheumatology question, if that's all right.
Yep.
A question from Dilbeer. I apologise if I pronounced their name wrong. They ask, will there be a recruitment drive for rheumatologists to meet demand? So do we feel we've got enough rheumatologists? And if not, have we got a plan to do something about that?
So I suppose this comes to that we've been, and I'm assuming you're based in Telford and Wrekin area, because we really have been struggling with our staffing levels there. So I can only apologise. So we have actually done like a huge amount of like recruitment, and we're expecting to be pretty much fully staffed by mid-April onwards, both for our CNS, which is basically our nurses, and also for our consultants, which will be a huge step forwards. I think the other thing that's really, really useful is that when we have the bigger, so like the bigger area that we're looking at, it will make it significantly easier to actually move staff around where the biggest gaps are, to make us significantly more responsive and ensure that one area is not disproportionately negatively affected by vacancies than others. But yes, we looked particularly at this model. We looked at this bottom-up approach. We looked at what do we need to have in place to make sure that we're meeting our waiting list requirements, to meet our any standards of care that we need to have, and that's where we worked our staffing model up from, and we expect to have the full staffing complement in place by the time of go live. So I would really hope that people will see a significant difference in how their care will be delivered, with the caveat of COVID. Sorry, I am putting that one in there.
Thank you, Karen, really helpful. Thank you. Richard, back to you, and I am conscious now we've literally only got about 3 minutes left. I've had a question, just a couple more engagement related points. So it was mentioned earlier that we'll still be doing more of this kind of thing. Somebody asks, is there the opportunity for any changes to be made based on feedback you hear in these events?
We're always open to input, always open to input, and it has to be obviously balanced with all the things that we have to balance with this. But we would be very happy to get more engagement on that. I see that Louise is putting her hand up, so over to Louise.
There you go, Louise.
Thank you. Follow on from that. This is a transformation journey. It's not we're going to change it now and that's it. So we will be monitoring any impact of things that we introduce. And if following feedback, it seems that something should be altered slightly, then we will be taking that into account. So it's a continual growth of improving the service.
That's great. Thank you very much. Right, Louise, I'm conscious now it's 2 minutes to 12 and people have other places to be. Do you want to maybe just say a few words to bring this to a conclusion? And thank you very much to yourself, to Richard and for Karen for joining us.
Yes, I will. Thank you very much for joining us this morning and for your questions and comments. They've all been really useful. We all hope that you found this a useful session as well. We will be holding similar sessions in the future, and Richard and I will go away and plan that from today. And thank you also to my colleagues Richard and Karen and Chris for helping with this session. So if there was one key message for you to take home today, it would be that we're developing this service to improve the care we offer for our patients, ensuring an equitable service for all. So thank you very much.